legislation, proposed legislation, and propositions, but this is a conversation that's also happening around the nation. And one of the things that I kept thinking about related to this topic, especially when I was first asked to testify at a joint health and judicial committee hearing several years ago, and this is just how I think, so you're going to have a moment in my brain, is what does the data tell us about how um, involuntary commitment, conservatorship, is helping people? And in reading a report that was jointly done by the Health and I think it was the Judicial Committee, I found, well, there wasn't any data. The data was really scant. It was sort of absent. And some of the data that was existing told very interesting disparity stories. So I had to ask myself, well, wait a minute, who's minding the store? Who's minding the shop? Who's looking at this? And why would we advance something in which we don't even have all of the data? Less than 50% of our counties are reporting on who's under any kind of LPS orders. So that's kind of where this all started. I didn't have some words for this. I just sort of knew that something was amiss. And as a person with lived experience of a mental health condition who has been under LPS orders and the like, I have issues about that. I have issues about what happened when I was under these orders, what didn't happen, etc. So that's why I thought this was an interesting topic. When I came across the book Conservatorship Inside California's System of Coordinated Order, I will tell you it's not about the system. It is huge. It's 300 pages of text and then another, 70, 80 pages of references and notes. So I want to introduce the author of this book, Alex Barnard. So if Alex could kind of jump in. Hey, Alex. So why don't you introduce yourself now that I've introduced the topic just a little bit and why there's interest.
Sure. So I'm Alex Barnard. I'm an assistant professor of sociology at New York University, but did my doctoral degree in sociology at University of California, Berkeley. And although I left California in 2019, I sort of still consider myself, I guess, an honorary Californian. So it's wonderful always to be virtually back. I'm so grateful to be here. I'm also very intimidated because it's one thing to present this work to a group of sociologists, and it's something else to present this work to a group of true experts in this topic. I mean, there's so much experience and expertise of people advocating and working in this system in this virtual space. And so I'm both really grateful to have a chance to share my work with you all, but also prepared for and hoping to get some critical, thoughtful feedback from all of you.
So great, and thanks for that introduction. And I note one thing about you and about kind of how we talk about this topic or who's talking about it, that you describe yourself as a sociologist. Okay, what? So what is a sociologist and why would a sociologist have interest in this topic?
Yeah, I mean, I think sometimes when I tell people I'm a sociologist, I think they either hear that I'm a socialist or I'm a social worker, and maybe it's somewhere between those. But as a sociologist, we're people who study human behavior. I came at this topic as somebody who's really interested in decision making in the medical system, and public policy. But what does it mean to be a sociologist studying this in particular? I was thinking of a couple of things. I mean, one piece is that as a sociologist, I'm lucky to be able to move between multiple communities. So this research I'm a qualitative sociologist, which means I don't really work with quantitative numerical data. What I do is I interview people and I conduct observations and I look into historical documents and try and piece together the narrative of what's happening. And for this book, I interviewed about 300 people up and down the state, and feel really grateful to have been able to interview people who have really divergent opinions on some of the key questions, like should we reform conservatorship criteria? But I think as a result of being able to move between those communities, and it's what I hope we can do a little bit of today, I think I was able to see that there are some, there are some things that people throughout the system agree on and see together and potentially could work together towards. I think as a sociologist, we're really trained to think in terms of not why people make bad choices, but why sometimes our systems don't give people any good choices to make. So this book isn't written as kind of an expose of this group of bad people who wants to coerce like that's the story I'm telling is not homeless people who are making bad decisions or sort of psychiatrists who have this terrible like my perspective is really coming from a systems perspective and asking like how are people muddling through this system that really doesn't function well. And then I think the last thing, and this is a bit the core of the book, of the tome. I don't know how to I think that's accurate, but I don't quite know how to feel about that descriptor.
It's a good thing.
But as sociologists, we're trained to pay a lot of attention to power and inequality, and I think what that helped me see is we have these two different narratives. One is people who say it's impossible to force people with mental illness to do anything. The law is so strict, you can't override people's refusal to their decision not to take treatment, and as a result, they're dying on the street. And then if you talk to people, living with mental illness or identified as having mental illness, they say, actually, there's all these people who are coercing me all the time. Like I'm getting taken to the ER and being incarcerated. Like it seems like there's a lot of people who have power over me. And I think what I, tried to say in the book is, on one hand, we have a system where there are a lot of actors that have power over people with mental illness. There's law enforcement, there's the courts, there's clinicians. But there's really very little authority over that conservatorship system itself, right? There's no one that's, taking responsibility for it, that's regulating it, that's monitoring it, and that's making that system accountable to work together towards the best possible outcomes for individuals. So that's what I'd like to think that a sociological perspective brings to the table. It's certainly not above and beyond the other kind of expertises that are represented here specifically.
Yeah. So thanks so much for that description. And when you talk about sort of power over and then thinking about, but wait a minute, who that there's little authority over the system as it exists. That's the thing that I was so struck by that I actually wasn't even aware of until I had to give this testimony and then had to fit it in some kind of context that was not just my lived experience, but my lived experience as somebody who's been under these orders, also a lived experience as a family member who has had a family member under similar orders, that I needed to kind of step up and outside of that to figure out what the heck is going on. and why is it going on, and where did all of this come from? So can you talk a little bit about, like, just let's start at the beginning here, right? So what is the state of involuntary treatment in California from your research?
Yeah, so I'm gonna share my screen to give some visuals. As a college professor, I'm very wedded to my PowerPoint, but hopefully this is helpful. I mean, the repeating theme for anytime I talk is that we really lack good data on all of these involuntary treatment measures, and that I think that's really the basis of accountability is that you have a count, and so it's certainly concerning that we don't have good data. But I'm going to show you a little bit of the data that we have. So the graph I'm showing on the slide right now is showing the rates of short-term involuntary holds. So this is when a law enforcement officer or clinician places somebody under some sort of temporary detention and brings them to an ER for an evaluation. In California, that's called a 5150. And the graph is showing the best data we have about how the rate of these short-term holds relative to the population. And what you can see here is this is about 30 states that have data that's available, and California is number 5. So Florida is the highest, but California is on the high end of this. So whatever the law is in California, it's not preventing, large numbers of people from being placed on these temporary 72-hour detentions. So now what I'm showing is another graph looking at what we might call medium-term involuntary treatment. So in California, that's a 5250. So it's when somebody has stayed the 72 hours of a 5150. They've been admitted to the hospital, and a psychiatrist has determined that they're still a danger to themselves, a danger to others, or gravely disabled, and so they're going to be detained for up to another 14 days. And this is where it's hard to make apples-to-apples comparisons, but this is looking at the number of 5250s in California versus a bunch of other mostly European countries the rate of involuntary hospital admissions in those countries. And here, the graph is showing that once again, California's a bit in the middle of the pack here. So it's a little bit below France. It's a little bit above Switzerland, but there's many, many more involuntary hospitalizations happening in California than a place like Italy, Portugal, Ireland, or Denmark. So there are many countries that have fewer involuntary hospitalizations than California, and then some that have more. So the third slide I'm showing is about long-term involuntary treatment, and this is conservatorship. So probably most people here are familiar, but a conservatorship is another word for a legal guardianship in which a court gives a third party, which could be a family member, it could be a private professional, or it could be a county public guardian, and gives that entity, that individual, the power to decide where somebody's going to live, to consent to treatment on their behalf, and to control their money. And what this graph is showing is that the number of people under conservatorships for a mental health disability in California, it rose from the 1970s to 2000 to about 18,000 people in the state.